Hello and welcome to iStream Ophthalmology, learning ophthalmology made simple by Dr. K. Suresh. Today we are going to learn about Worth 4 dot test. Worth 4 dot test is normally used to evaluate the sensory functional status of the eyes. So it is normally used to find out whether a person has normal sensory fusion, or is there suppression, or is the patient having diplopia or anomalous retinal correspondence. So what is the basic principle of Worth 4 dot test? The basic principle is binocular dissociation. So how do we achieve it? The target presented to both the eyes are same. Basically it is 4 dots with different colors. So how are we creating this binocular dissociation? The patient has to wear a spectacle with glasses which has different filters. One has a red filter, another has a green filter. So here the dissociation happens. The light which passes through the red filter suppresses all the green images, and it only the red images are perceived by that eye. Whereas the eye which has the green filter in front of it, here all the red images are suppressed and only the green images are allowed to pass through. This is how binocular dissociation is achieved for Worth 4 dot test. So what are the basic requirements to do this Worth 4 dot test? One is the Worth 4 dot display or the 4 dot display. We have two such displays. One is for the distance and another is for the near. And we have what is known as the red green goggles or Armstrong goggles, which is worn by the patient when doing the test. So it is a very simple test with very minimal requirements. Let's see what are the types of Worth 4 dot tests. Basically there are two types. One is for distance and another is for near. As I already told you, there are two types of displays. So the distance display is used for the Worth 4 dot test for distance. The near display is used for doing the test for near. So why do these two tests at different distances? The test done at 6-meter distance subtends a visual angle of roughly 1.25 degrees. So it is used to evaluate central fusion, whereas the test done using the near stimulus, which is basically 33 centimeter distance, subtends a visual angle of 6 degrees. So it is used to evaluate peripheral fusion. How do we go about doing this test? So depending on whether we want to do this test for near or distance, the appropriate stimulus is placed in front of the patient. Then we ask the patient to wear their best refractive correction, and the red green goggles or the Armstrong goggles has to be worn over their best refractive correction. If we want to assess the depth of suppression, then we also need to have a control over the ambient room illumination. Otherwise, this is not required. So once the setup is in place, we have to do a baseline verification if our filter is working properly or if there is proper vision in that respective eye, whether the patient is able to perceive the stimulus. So first we test the right eye to confirm the right eye filter. We close the left eye and ask him to tell us what he sees. Normally, since the red filter is present in front of the right eye, patient is able to perceive only two red lights. Then we go on to cover the right eye and ask him to see with the left eye. Here, since the green filter is in front of the left eye, the patient will say that he is able to see three green lights. Then we open both the filters and ask the patient to see with both the eyes. This is binocular testing. So if the brain is able to handle both these different dissociated lights simultaneously, then the person will say he is able to see four lights, that is one red, two green, and depending on the dominance, the patient might say third dot as green or red. So this, if he says four dots, then this suggests that the patient is having binocular vision. Now, I previously told you that when all four dots are shown, the person might either say the lower dot as red or green. But at times, the brain perceives both the red and green wavelengths at the same spatial location, blending them into a single luminous yellowish dot. This phenomena, where the patient might call the fourth dot as yellow, is known as lustre. The other type of response is when the patient constantly gives only one response. He either says, I'm able to see only three green lights or only two red lights. Okay. So, what is the meaning when the patient says, I am able to see only three green lights? We know that the red filter is over the right eye. So, if the patient is not able to see any red light, that means the right eye, there is no visual stream, or the right eye is not able to see. Okay, that is suppressed. So, whenever a patient says, I am able to see three green lights, that simply means he is having right eye suppression. Now, let's see the other response. If the patient continuously says, I am able to see only two red lights, that means since the green filter is over the left eye and the green dots are not being perceived, that means the brain is suppressing the left eye. Okay, so when a patient constantly says, I'm able to see only two red lights, that means his left eye is being suppressed. Okay, so let's see what are all the types of responses a patient can give to a Worth 4 dot test. So sometimes instead of saying four dots, the patient might keep on altering their response. They might say at one point of time, they might say that they are seeing only two red dots or only three green dots. So please don't get frustrated that the patient is trying to mislead you. Actually, the patient's visual system is lacking the stamina for continuous fusion. So what happens? There is rapid alternating suppression between the right and the left eye. So whatever the patient is saying, it is that is simply because the other eye is being suppressed at that point. So when he says I am able to see only two red lights, that means the left eye is being suppressed. And when he is saying I am able to see only three green lights, that means at that point his right eye is being suppressed. So such a kind of response is because of alternating suppression. So let us see one more interesting response that the patient might give. When you ask him how many dots he or she perceives, the patient might say five dots. Now, whenever such a response is given by the patient, we must take the pain to ask them to locate where these five dots are. Okay, so if the patient sees the red light, that is the two red dots on the right side and the three green dots on the left side, it is uncrossed diplopia, because we know that the red light is being perceived by the right eye and the green light is being perceived by the left eye. Okay, since the image of the right eye is in the right side, we call it as uncrossed diplopia. And if we go on to examine the patient will have esotropia, that is inward deviation of the eye. So when we come to the other response, where the patient says, yes, I am able to see five dots, but the right dots are in the left and the left dots are in the right, that means it is crossed diplopia because the image seen by the right eye is appearing in the left, the image seen in the left eye is appearing in the right. So it is crossed diplopia, and on examining the patient for ocular misalignment, he will have exotropia. At times, we get a very interesting response for Worth-Ford dot test. What is it? Let's see. Now, here is a patient who has obvious squint. Correct. So, what do we expect the response to be? Naturally, we want this patient to say that I am seeing 5 dots because we expect diplopia in the presence of strabismus. But when you ask the patient confidently says I am able to see only 4 dots. So, what is happening here? Is the patient misleading us, or are we misdiagnosing the squint? But the squint is very obvious, right? So, what is happening here? So, this is a condition known as anomalous retinal correspondence, where a patient with visible strabismus still has normal binocular single vision. So, the patient is not trying to mislead, he is actually seeing 4 dots. So, how is this happening? Because of obvious strabismus, the brain has remapped the spatial coordinates. So, here for this patient, in the deviated eye, a extrafoveal point is doing the work of the fovea, and this extrafoveal coordinate has been remapped by the brain as fovea. Okay, that is why, in spite of the patient having an obvious strabismus, he still continues to have normal binocular single vision. Such a condition where a patient continues to have normal binocular single vision in the presence of visible strabismus, it is known as anomalous retinal correspondence. Now, to detect suppression depths, not only is the distance at which the Worth dot test done is useful, even by changing the illumination at which the Worth dot test is being done can help us detect suppression. How is this? When we do the Worth dot test under full illumination, it closely mimics a natural visual environment. So, if there is suppression when you're doing it at full illumination, it simply means that this suppression is shallow. Whereas when we slowly dim the light, it removes all peripheral cues for fusion. So it is a highly unnatural dissociative environment. If the suppression persists even in a dim illumination, that means the suppression is deep. So the Worth dot test, by changing the illumination, it can be a therapeutic indicator. If the suppression breaks when the lights are dim, that means this patient will respond very nicely to vision therapy. So, take home point, a scotoma or a suppression detected at full illumination is shallow, whereas the suppression detected at illumination is a deep or dense scotoma. So, what else can we identify using the Worth dot test? I have already told you that it can be done for distance and for near. The near test has a large retinal angle, basically 6 degrees, and the distance has a small retinal angle which is roughly around 1.25 degrees. So imagine a situation where there is a small central suppression scotoma. How do we detect it? So when we do this, first we have to establish fixation. So we start by doing the near Worth dot test. So since it is a large retinal angle, it will mask the small suppression scotoma and the patient will continue to see 4 dots. But as we slowly retreat this stimulus towards the distance, there will be a distance where one of these dots lie exactly over the scotoma and it disappears. So we can identify subtle central suppression scotomas by doing this Worthford dot test for near and distance. So to conclude, the Worthford dot test not only helps us diagnose suppression, diplopia, anomalous retinal correspondence, and alternate fusion. It also helps us by serving as a therapeutic index. Depending on the findings, like I already told, if there is a shallow central suppression, it can be broken by dimming the lighting. That means the suppression is very shallow, and these patients are very much amenable to vision therapy and binocular training and anti suppression exercises. If the patient has consistent diplopia, then prism correction, they respond very nicely to prism correction. Just optical displacement of the image is enough for these patients and they respond very nicely. Suppose the patient has a very large deviation and a deep suppression or a dense scotoma, that simply means this patient requires surgical intervention. So, Worth-Fodor test is not only just a diagnostic test to find out whether the patient is having binocular single vision, it can also act as a therapeutic indicator as to how to proceed and what kind of therapy the patient will benefit. This is not absolute, but it can be used as a generalized indicator for future therapeutic response.